Okay, good afternoon, everyone. You're all very welcome to this webinar. My name is Deirdre Shanley, and I'm the Assistant Secretary in the Department of Education with responsibility for schools. I really appreciate that many of you have been teaching and working all day remotely, so I thank you for taking the time to come to this webinar. This webinar is focused on COVID-19 and the public health approach to COVID-19 in schools. There has been a really strong demand to attend this webinar, so we're both on the webinar platform and we're also been live streamed on YouTube. I want to thank very much our partners who have been supporting us to facilitate this webinar. Thanks very much to Tralee Education Centre and particularly for IMS for making this webinar possible with their Zoom technology. I'd also like to thank very much today the public health specialists who are giving of their time to support us in terms of this webinar this afternoon. So this afternoon we have Dr. Ronan Glynn, the Deputy Chief Medical Officer, Dr. Kevin Kelleher, the Assistant National Director of Public Health with the HSE, and Dr. Abigail Collins, who's a Public Health Consultant with the HSE. Both Kevin and Abby have been working intensively with the school sector since schools reopened in September. As you're all aware, the department are working with public health on an ongoing basis, and we're also working with the teachers and the SNA unions, the school management bodies, parents and student representatives towards the shared goal of putting in-person education back in place for all students. At the moment, we're particularly focused on working towards the shared goal of supporting students with special education needs with face-to-face education from Thursday of this week, Thursday the 21st. We are specifically focused at this point at special schools, at special classes in primary schools and students with special education needs in mainstream classes in primary schools. We realise there are a lot of questions that many people want covered by this webinar. We've received a lot of emailed questions over the course of the weekend, and there is also a question and answer, facility on the webinar. We want to cover as much of those questions as possible in relation to the public health advice on suppressing the virus in schools, the data that has been used, and the information that we have about the transmission of the virus in schools. There are also some questions coming through that are not specifically public health questions. Some of these questions relate to the operational aspects of returning to school. These are going to be addressed in the guidance that the department has already issued to schools, and also on further guidance that we're working on today and in the next couple of days with the partners in education. Some of these guidance include issues around pregnant workers in schools and also around specific arrangements for high-risk staff. And we will be communicating those guidance particularly to schools in the coming days. Today we're concentrating on the public health approach, and we'll be putting questions to our expert panel and hearing from the public health experts. Many of the topics that people are interested in terms of the questions that have already been submitted to us will be covered in a presentation that's going to be given at the start of this webinar by Dr. Abby Collins. And we'll also have specific questions then that we'll address to the panel later on in the webinar. If you're watching via the live stream on YouTube, you can submit a question via email on c19schools@education.gov.ie. So I'm going to hand over now for a few opening remarks to Dr. Ronan Glynn, the Deputy Chief Medical Officer. Thank you, Ronan.
Thanks very much, Deirdre. Can you hear me there okay? And good afternoon, everybody. I suppose just a few remarks to open the session. I suppose as many of you will be aware, the kind of key drivers or the key underpinning principles that have been at the heart of all that NPHET has tried to do over the last number of months has obviously been in the first instance to protect the public from COVID and to avoid the kinds of rates of illness and unfortunately mortality that we're now experiencing in the country. Secondly, to protect non-COVID health services like cancer screening, cancer services, and all of the other range of healthcare services that people need. But then thirdly, a key principle has been to get our children back to school after the experience that we had last March and April. And then aligned with that was to resume and protect the provision of childcare services. But we've also been clear all along that were we to see very high levels of community transmission, that would threaten the ability not alone to protect education, but to protect all of our key societal priorities, including the provision of non-healthcare services and of course childcare services. That said, the experience from September to December in education was a very positive one. And I'm sure we'll hear more from Kevin and Abby in due course. But, it's clear that the incidence in children over that period was at all times below the population average. And for example, in October, only about 10% of cases in children overall were actually linked to outbreaks in schools. And that's not to say that there haven't been issues. It's not to say that there haven't been challenges. But by and large, the experience was a positive one. And that's largely down to the work of everyone involved in the education sector, be that the Department of Education, teachers, principals, boards of management, parents. People who played a phenomenal role did play a phenomenal role over the period from September to December in making it as successful as it was. I suppose all of that notwithstanding, we got to a place after Christmas where we were dealing with a level of disease that we simply haven't seen in this country previously, with all of the challenges that poses. And in that context, we wrote to the Minister for Health on the 5th of January. NEFIT met and wrote to the Minister. And I would encourage all of the attendees to maybe go online to gov.ie. And if you go to the Department of Health or the COVID link on that, you'll be able to see all of our letters to the Minister. But the one of the 5th of January specifically deals with the issue of children and schools. And so I suppose there's a few key points that I'd like to bring out just at the start of this session. So the first was, and I know many of you will be tired of hearing us say this, but the experience to date does align with the fact that schools in themselves are a safe environment. But as I said earlier, whenever you have levels of transmission like this, the reality is that schools and everything else we provide are threatened. And unfortunately, that came to pass. And so we noted that in our letter, the 5th of January. But it's important to, I suppose, just to explain the reasons why we said what we said. And the key driving factor behind it was very widespread community transmission, escalating numbers of cases, escalating numbers of hospitalizations in ICU. We just couldn't see a way that 1 million people could continue to interact on a daily basis in the way that happens when there's full opening of all schools across all parts of the sector. And so our advice at that stage was that really that schools needed to close for a defined period of time so that we could bring community transmission under control. But we were clear also in that letter that specific measures should be taken to protect more vulnerable children, recognising again the very disproportionate impact that the previous measures have had on them over the pandemic to date. So, I mean, I don't want to go on too long, and I know that Abby and Kevin will bring more data and will bring more real life experience of managing outbreaks and managing this over the past number of months. But I suppose I would just like to thank everyone for all of your input over the months to date. To reiterate NEFIT's view that schools in themselves are a safe environment, that we haven't departed from our original view that rates of transmission in children are significantly lower than in the rest of the population. But that said, whether it's schools, whether it's non-essential retail, whatever part of society given time, people need to take protective measures. And when schools reopen, or whenever parts of schools reopen, people need to take all of the protective measures that they can to protect themselves and each other. And there's no getting away from that, and there's no sugarcoating that. As long as we're dealing with COVID, we're dealing with a risk, and there's no zero risk environment. But that said, I suppose the challenge we all have as a society is to balance up the risks and the benefits, and to look at things in the round and come to a balanced assessment of what's appropriate. So from our perspective, we would certainly be hoping to get schools open again as soon as possible, recognizing that it is a societal priority, but also recognizing that the time for that isn't just yet, given, as I said, that involves about 1 million different people coming into contact with one another on a daily basis. So I might hand over to Abby and Kevin, but again, I just want to say thanks again for your forbearance and for all that you've done over recent months, because I know that it's not easy when you have to deal with all of the uncertainty that comes with coming into contact with colleagues and with children from a whole range of different households on a daily basis. So I just want to re-emphasize that's not lost on us when we make our recommendations and when we consider all of the evidence that comes to the table at NPHET. Thanks again. Thanks, Deirdre.
Thank you very much, Ronan. So I might ask Abby Collins, Dr. Abby Collins, to come in now with her presentation. And Abby is going to cover some of the questions that have been coming in over the course of the weekend in terms of the reopening of provision for special needs children. So Abby, if you want to start off, thank you very much.
Okay, hi everybody. I hope you can hear me. Sorry, I was talking with the mute button on. I hope you can also see my slides if I take that to slideshow. Okay, thanks very much for that introduction, Deirdre. Yes, my name is Abby Collins. I work as a public health consultant and have been leading on lots of the work pieces related to the schools and the educational sector over the previous term. So just want to share some of the findings, some of our experiences, and talk a little bit about where we're at currently. So just going to briefly outline the public health approach, discuss the public health risk assessments that we undertake and the whole process of identifying the close contacts, the testing and the tracing, and what some of that data has shown us. Discuss some of the clinical points that we've found and consider in the current context. So in public health medicine, we're all about prevention and protection. And if that's not possible, we try to find potential cases, and then we follow up on confirmed cases when we have confirmed cases as our last resort. And the public health risk assessment is a routine part of all public health work. And this really enables the most accurate and effective determination of the likely health impacts of a range of possible interventions. So for schools, there are 3 components to the public health risk assessment. That's the schools component, the case component, and the community component. And many of you might have been aware or become aware of the schools component, at least through our work over the last term. So what do I mean by that? Well, in essence, it is a forum that is specific for the school setting, and we ask lots of questions. So it's a standardized, protocolized process in terms of the questions and the information that we need to get from the schools and from the cases and consider from our communities. And we use that information obtained across the 3 different settings to inform us in who we're going to determine as close contacts. So as I said, the close contacts are identified through this process, and we may well have a number of contacts identified with 2 different cases, even with different classes. And I suppose that's really important just to point out that a systematic approach to something doesn't always mean that the outcomes are the same or comparable, because every single class is different, every single school is different, every single type of school is different, as I'm sure you appreciate. So it's just to flag that as a start, because I know that has been an issue over the previous term as to the apparent differences in outcomes from our risk assessments undertaken. As I'm sure everyone knows now, once close contacts are identified, they are excluded from the school setting, or any setting indeed. They're asked to restrict their movements and they get referred for testing. And the testing for schools is prioritised and coordinated through the school's testing pathway for both the staff and the students. And despite the recent difficulties in terms of the testing and the close contacts testing out in the community, it very much remains the close contact testing pathway will be undertaken within the school setting. So that remains unchanged. So the resulting we get is really important. That's batched resulting, and it enables the most effective public health management, because for us we need to consider the wider exclusions and testing that need to take place. So whilst one result is important for the individual, all of the results are actually important for ourselves. So we have recommendations then for more enhanced mitigations or resilience to mitigate against further close contacts being identified. So that's as a follow-on from the public health risk assessment. So in terms of the close contacts and the details, there are information resources available to you. There is frequently asked questions for schools, a document that's available for you. There's a parent's guide to close contacts, which we hope is useful in the context of the children who are designated as close contacts. And there are some short YouTube video clips as well to assist people in understanding what that means. We also have schools teams, and they've been in place right from the start. They are clinically led by colleagues of myself, public health medical colleagues across the country in our 8 departments of public health. And since the midterm, they've been strengthened with educational expertise as well, which has been really valuable for us. We also have the HSE principals line in place to ensure that you have swift and easy contact through to us and through to the correct Department of Public Health for follow-up with concerns of cases of COVID-19. So what's some of the data that we've identified through the process? So over the course of the previous term, in total, we've undertaken public health risk assessments and onward testing in just over 1,100 facilities across all the educational sectors. And you can see, particularly in the special educational needs sector, the schools there, we've undertaken 51 public health risk assessments. So that's over that period of time, we've developed really nice understanding and experiences across the whole of the educational sector through the public health risk assessments, but specifically including classes and schools facilitating children with special educational needs. So in total, nearly 35,000 people have been identified as close contacts and onward testing, and our detection rate overall is 2.7%. So that is for someone, when you've got a case identified, when we look to their close contacts, so the people who are not got any symptoms, who were exposed to the case, how many of those turned out to be COVID-19 detected? So overall, that is between 2 and 3 in 100, and specifically in the special educational sector, between 3 and 4 in 100 people. So this graph just shows a little bit how the testing has been undertaken over the past term, and you can see that there have been peaks here where we've done a lot more testing, and this pertains to sort of October time when we had an increase in the numbers, and you can see another increase as we headed in December with very high levels of infection too. And this is because what we notice is what happens in the community then follows and happens in the school environment. So we see a slight delay, but we know if there are more cases in the community, we will then see an increase in the cases who are presenting in the school pattern. And that's well identified internationally, that what happens in the communities what happens in the school follows what happens in the communities. And if we look over the course of the few months just to see what's happened, we can see this is particularly, this is specifically for the special educational sector. You can see that the close contact positivity here has remained relatively stable, much lower in November, but there were a lower number of cases. So overall, the numbers tested were much smaller. So when you have smaller numbers, then there is, it's a little bit less robust, the data we call it. So with the other months, you can see that they're very stable and they're around the 4%. In terms of where we're at just now, and the number of cases of COVID-19 over the past week identified in 0 to 18-year-olds is 2,711. So that's approximately 0.2% of the population, 0 to 18 population, that is. So even though the case rates are very high, the actual case numbers in that school-age population are still low. This graph looks at the number of confirmed cases of COVID-19, and this is for all age groups. So we can see here that when we started the schools opening around late August, September time, the rates were fairly low. We had the peak as we had in October time, and then obviously late December, we had a very significant increase in the number of cases. The coloured lines here denote the different age groups amongst the school age children. So the yellow is the primary age, the little yellow line there. The purple one is the secondary line, and then we've got the preschool age line there. And you can see that they're very substantially and significantly lower than the all age groups' actual number of cases that we've been seeing. So what are some of the clinical points? Well, children generally are more likely to have a mild disease. We have learned that over the course of COVID-19 over the last 10 months. And they're not the drivers of infection of COVID-19. So when we're notified of a confirmed case, that individual is already out of the school environment, and that's really important to remember. And were they to have been in the school environment, then we will, within their infectious time period, which is 48 hours before they had symptoms or 24 hours before they had a positive test, if they were tested as a close contact, for example. So were they to have been in the school environment, then we in public health come in and we undertake our risk assessments. But the incubation period is up to 2 weeks. The average incubation period is 4 to 7 days. And what I mean by incubation period is if someone was in the class who had the infection and then they were to spread it to somebody else, the person next to them, it takes 4 to 7 days on average, but up to 2 weeks for that person, that next person, to develop the infection. So there is time for us to come in and identify those close contacts and make sure that they're excluded and out of the school environment. So we also know that with mitigation measures implemented and in place, it does maximally help prevent onward spread. Nothing is absolutely certain, and nothing can always reliably be 100% mitigated against. But we do know that with the mitigation measures in place, the information and data internationally, but specifically in the Irish context that we gathered last term when we were doing our risk assessments, shows that we can have a much lower level of onward spread of infection within the controlled environment of the school setting than, for example, in many other settings. The community close contact positivity rate and the household close contact positivity rate are much higher, between 10 and 15%. So we do know that we can have some impact with our mitigation measures. And these are really, really important to make sure we maximally implement for the safety and well-being of everyone. And it has a role for us all, really. There's a role for us as a society in terms of prior to attending any facility. So the greater school community, parents, families around. There's the importance for the measures within the facility. So that's about reinforcing all the mitigation measures that have been asked to be put in place within the school environment. And then, of course, a role for ourselves in public health to identify people and exclude them and follow them up and make any recommendations as we identify. So what are some of the clinical points prior to attending the school? Well, the school community really altogether need to follow the national public health recommendations to ensure that we can keep the school community at the lowest risk possible. And at the moment, those public health recommendations are very significant. It is for essentially everybody to stay at home and minimize their social contacts as much as possible. And the important part is that no one with symptoms consistent with COVID-19 should be attending school without having discussed with their GP, be they staff or student. And on top of that, I think it's so important that we really, really do take a precautionary approach to this. So if someone is off form, and classically what we've learned from our risk assessments over the past term is that it is often more difficult with some of the special needs children to be sure they can't express often the symptoms in the same way. But you know the children, As staff members and families know the children very well, obviously as part of their families. If something isn't quite right, then there is a precautionary approach that needs to come into play, that you hold off going to school, that you stay at home and see, does anything develop? If nothing develops, that's fine, but it's better to take a precautionary approach. If things do develop and symptoms then become more clear or more concerning that they could be COVID-19, then obviously they need to be specifically discussed with the GP and testing arranged appropriately. The clinical points within the school, I think, are fairly clear to most people at this stage, but maximally implementing them at all times is so crucial. So having the isolation room in place in case some part of that preschool attendance falls down and someone becomes unwell within the school setting. Having the rest of the infection prevention control measures in place, such as the face covering or the use of medical grade masks as appropriate for the very close work. And it is absolutely acknowledged the close and intimate level of care that is required for many of these children, and that sometimes there are behavioural difficulties that make that even more challenging. And you know, that is something that we attend to in our risk assessments and appraise as part of our discussions. You know, we're all doctors amongst us who make the clinical decisions. Myself, my background is in paediatrics, and most of my colleagues who are undertaking this work, their background is in paediatrics or general practice, or as medical officers working across the area with the child services anyway. So it is a setting that's familiar and nature of work that is more familiar to us than maybe other areas of the healthcare sector. The social distancing where possible is really crucial. Obviously within that intimate care network, we absolutely appreciate that that is very challenging, and that doesn't happen to the degree that we would recommend at a national level. But outside of that intimate care network that is developed, it's really important that that social distancing is maintained, particularly at rest times and break times. And that is very hard for us all. It's hard for us in healthcare, it's hard for us everywhere to make sure that we don't have a break from the implementation of the measures, because unfortunately the virus doesn't take a break in terms of transmission. Hand hygiene is absolutely crucial and very important to maintain regularly and as per recommendations before and after certain activities. And maintaining suitable and appropriate ventilation for the rooms and settings that you're working in. And then in terms of the public health actions, well, as outlined, we undertake the public health risk assessment. So we take the information across the 3 domains that I've already discussed. We'll organise the onward testing and analyse that data accordingly. And then we discuss things. So I work based out of the Midlands here, and I discuss with the teams locally with cases. I've been in contact with schools myself, and we discuss amongst ourselves any of the more difficult scenarios that might come to play and make sure we make the best decisions we can. We also have national meetings twice weekly where we discuss lots of the more difficult cases or some of the issues that we're finding, to make sure that we can feed back and implement measures broadly as required, or make new recommendations as needed, and to share the good learning and understanding and practice from the public health perspective. So what's the current context? Well, it is high community rates of infection. We all know that, and it's been a very challenging few weeks for everybody, either in terms of staying at home, or for those of us, particularly in the healthcare sector, having to work, and for other people who undertake essential work. There's a new variants of infection being described and discussed, and those need to be monitored very closely. And we monitor the impact, we will be monitoring the impact of that very closely going forward. And if we have any concerns that that is changing what we are seeing, then obviously we will raise that and discuss that very clearly. So everyone is being asked to restrict their activities and their movements, and that's really to maximise the safety for those of us who do need to work. For those of us, the essential healthcare workers and essential retailers, there is an acknowledgement in society that not everybody can stay and restrict their movements maximally, that some of us need to go out and staff the hospitals and the healthcare facilities, and we all need to be able to access food, etc. But we have also learned how much and how profound the impact of lockdowns has been on children and families, particularly for children and families with special educational needs. And it's that has made the concerns and the priority such a high one for us to consider how we can safely move forward to impact and mitigate against those effects for children and family. Safety is always a balance of risk. It's never an absolute in any setting, either COVID or non-COVID. And as I said, the highest rates of infection we see are amongst the household setting from close contacts. So there is no place where it can be guaranteed to be safe, either from COVID or non-COVID. It's about trying to ensure that we identify and mitigate as best possible the risks of one thing, whilst balancing the risks and gains of another level, such as the access to education. But in this setting, a lot of direct sort of healthcare needs of children and families. And the data in Ireland has shown that we can impact on mitigating those risks with all the precautionary and preventative mitigation measures in place. There is just a link to a few resources here. The data that we produce is produced weekly and up on the website, on the HSE website. There's the gov.ie website and the HPSC website, which has a lot of the infection prevention control recommendations. So just to make sure those links are available for you. And I'll stop with the presentation there. Thanks.
Okay, thank you very much, Dr. Collins, and thank you also very much to Dr. Glynn. I might just move to a few of the specific questions that have come in that maybe haven't been covered in Dr. Abbey's presentation. Specifically, maybe first to deal with concerns around the new variant and whether or not there's any change necessary in the infection prevention and control measures in place in schools in the context of the new variants that really have come into play since December. And I might ask Kevin to come in, Dr. Kelleher, to come in on that.
Thanks, Deirdre. Hello to everybody. I'm really pleased that you've all managed to make it. The numbers are stunning, and it is clearly a very important issue for yourselves and us about this and how we get to have the schools open again for this very special group of people, the children who need this extra input to make sure that they develop over the time. The new variants are, it would appear, more transmissible, but actually the measures that we have been saying that should be put in place over the time are as applicable before them as they are now. It is putting them in place, as Abby said during her presentation. It's doing that. And as Abby says, the real issue is the times when you're not as much face-to-face contact with individuals, but you're actually resting. And it's very important that people rest, but it's equally important that people take on board that in those periods they have to be just as careful as ever. So just as much as when you're out at the moment and you go somewhere, you go into a shop, you wear your mask and you do those things, it's just as important to still doing that when you're meeting other people in the school in the same way. That's the importance of this. And that's where we will make sure people are safe as a consequence. Both Abby and I, and I'm sure Ronan as well, but Abby and I, because we talk a lot about this, are absolutely committed to getting these children back to school because we see that benefit as being one of the most important. What we witnessed last spring, I think, was really very problematic, and particularly for this group of children. It really is important that we can try and get them back to school with your help, because the benefits are immense as a consequence. So just to be clear, the new variants are there, but our measures are the same. They will protect you if you adhere to them as a consequence.
Thank you, Kevin. One of the issues that has arisen is around symptoms to look out for, and whether or not there's been any specific change in symptoms that people should look out for in the context of the new variant.
No different. The main symptoms are the same, basically a dry cough, temperature, and loss of smell, loss of taste. Those are the main symptoms. They've been always the same. They're no different for this variant nobody has indicated anything different in the international literature and any of the media, the stuff we see. So no, it's not any different. It is those symptoms are the ones that people need to be doing. And as Abby said, what is very important is that people don't come into work if they've got any of those symptoms. It really is very important. We have seen in lots of different circumstances and settings where people have come into work because they are determined to come into work because they see the value of their work and they don't want to let people down, their colleagues, but they've come in with symptoms, and that's been a focal point sometimes for disease spreading quite significantly often as well in a number of different settings.
And can I
Thanks.
just come in on one point on that, Deirdre? Sorry, it was just to say that obviously our experience, and I'm sure lots of your experience, is that it's not easy often to identify some of those symptoms of COVID-19 in some children who've got other medical comorbidities or might have some chronic symptoms that are similar, or in children obviously who are unable to express some of the symptoms that they might be consistent with COVID-19. And that's why the precautionary approach is so important. You know, you've learned about the children that you're caring for, and parents know well their children and what's normal and when they're slightly off form. And it's really, really important at all times, but more now than ever, that if there are concerns, as I say, that something isn't quite right, just be precautionary, keep at home and monitor and see what happens. It may turn out to be nothing, but better to be precautionary. If it turns out to develop, then you speak to the GP. And just to say that there's no flu in Ireland at the moment. So if there's, you know, if there's any symptoms which appear like flu that we're hoping aren't COVID, it's COVID until proven otherwise, and to stay away from any facility, especially, of course, including school facilities.
Thank you both. So can I just maybe ask you to explore a little bit the fact that in primary schools and in special schools in particular, social distancing is particularly challenging and is obviously more difficult to achieve, and maybe just some comments from yourselves about the other measures in that context.
Abby, you go first, and I'll...
Yep. So we absolutely recognise that, and that's why it's really important, I suppose, for two things. One is to make sure that the delivery of the education and care that's required is as best organised to make sure that there are the minimum number of contacts that are required. So that pool of people that you're in very close contact with is as small as possible. So less sort of cross-covering or cross-care, and as much very clear who are the staff and who are the students to attend only within that close proximity space. And obviously there are the recommendations of the face coverings to be well worn and the appropriate PPE measures to take place as much as it's possible. But we absolutely understand that there are medical times and there are behavioural contexts which make that challenging. Now, that really behoves that all of the other measures around that intimate care piece are put in place as best possible. And so at all other times, all of the infection prevention control measures, such as the facial coverings, the social distancing, outside of that intimate care, the respiratory etiquette, and most importantly, the hand hygiene, are all implemented maximally, such that the only leeway is where it has to be that very tight component where that might not be physically possible or doable. So it's really important. It puts a sort of bigger onus, if anything, on the rest of the measures, but it also puts a really big onus on us as a school community to make sure that no one comes in if they have symptoms or if they're concerned that they might be developing symptoms within the population.
Okay, thank you. Just also to add to that, maybe to inform everybody on the webinar, the HPSC has recently issued new guidance on the 7th of January this year around the wearing of surgical masks for special needs assistants. And in particular, they recommend that surgical masks will be provided for special needs assistants when they are not socially distant and they're delivering personal care and attention for a period of time. So I think that clarifies the issue around the use of surgical grade masks in the context of special needs assistance. And in that context, just also on behalf of the department, to say that schools will be provided with funding to cover PPE costs associated with the return to school, and to ensure that costs like providing medical grade masks will be covered. It might be useful now maybe to talk a little bit about testing and tracing, and some concerns have been raised about the fact that close contacts in the community are not being tested, and whether or not that has any implications in terms of the school and the support to schools in cases where COVID arises.
Sorry, Kevin.
Yeah.
Do you want to come in, or do you want me to start?
Go
You're on
first.
mute, Kevin.
Yeah, no, I'll go for it. Sorry. It's important to note that, yes, at the moment, for a number of reasons, we're not actively doing it without any sort of thought, sort of actively testing close contacts. But in circumstances, we would be. So come Thursday, when the schools reopen, if there are instances, we will then move into the process where we will be testing the close contacts in the school scenario as a consequence. It's the same at the moment. We are testing close contacts in the hospitals and in nursing homes and some of the other scenarios as a consequence. And actually in the creches, that the preschool facilities that open, we are actually testing close contacts as a consequence.
Yeah, I'd just like to confirm exactly that we'll do the public health risk assessments and we'll undertake all the close contact testing as necessary. In terms of the family,
so yes, we will be doing that. Okay, there's a variety of reasons.
Sorry, I think we lost you a bit there, Kevin. In terms of the home close contacts, I was just going to say that obviously anyone who's designated as a close contact within the household setting should be restricting their movement. They won't be going, they will have to restrict their movement for 14 days. That's the current recommendation. So they won't be attending within the school facility at any time point, whereas the isolation for a confirmed case is 10 days. So if you act and follow the advice and recommendations for the 14 days, those close contacts won't be within the school setting themselves anyway.
Okay, and Abby, can you just clarify then, if somebody in a household is a close contact, what are the implications for other members of the household?
So if the case is within the household, the other household members are close contacts and they are all to restrict their movements. If only one person is within the household has been designated as a close contact as a result of contact sort of through work or some other setting, then they are required to restrict their movements, but no one else within the family is required to restrict their movements unless that person becomes symptomatic. As soon as that person or any person becomes symptomatic with symptoms consistent of COVID-19, then they must isolate and everybody else in that house must restrict their movements.
Okay, thanks, Abby. You mentioned in your presentation around the school teams and the support for school teams. Can you just confirm that those teams will be supporting schools when schools go back? Yes,
so we've had school teams within the 8 departments of public health, and they're now a mixture of clinical HSE staff and all the non-clinical supports we have for the whole testing process, and also with our Department for Education, our educational expertise colleagues, also as part of these teams, and the preschool inspectorate. So those teams are here and they are in place, and the special needs sector is a sector that we all as a public health community care very much about, and will be a priority for us in terms of the workload. It is absolutely true to say that, you know, with all the cases, public health is a very busy place, but we have those school teams in place, and we can and will be here to support the childcare facilities with the who are caring for children of essential workers. We are currently doing that, and we will be supporting that for special needs schools to special needs children referred into us. So yes, they're there and they're in place.
Okay, and they would have knowledge of the special education settings from their previous work?
Yes, so I mean the teams are the same teams as before Christmas, and as I say, you know, we've done thousands of risk assessments at this stage, and done, you know, 51, I think I said, especially within the special needs schools themselves, and we have twice weekly meetings. I know my clinical colleagues from across the 8 departments, and we talk closely and very regularly. So there's a lot of shared expertise, and obviously the educational redeployments into our teams give us fantastic insight and support too from their perspective.
Okay, some of the questions that have arisen are around the fact that some special needs pupils aren't being tested due to the stress that causes them. And has that any particular implications or concerns to yourselves from a public health perspective if they actually don't have a test because of that, maybe their inability to tolerate the testing?
Well, that's where we have an individual public health risk assessment. So that's taken into place, taken into account. You know, sometimes we take measures that we have to presume that they are a confirmed case, and we will contact trace around as though they are a confirmed case. In other cases, there are specific circumstances we can organise such that it might not be the usual testing practice, but you know, we are well used to working across the intellectual disability houses and settings. We've been doing a huge amount of work over the course of the pandemic in that setting, which is also a very challenging setting. So you know, we have options and staff who are used to dealing with that setting, and also we can consider the sort of the close carers. So for example, the parents, or if there's one particular home care, it may be that we look to get them tested. So you know, each situation is different, and that's why we have an individual public health risk assessment. We always take a precautionary approach.
Yeah, can I just add, it is very important that we look at all the circumstances and to make those decisions. And clearly, it's inappropriate if there is a difficulty in taking a test to go forward and take the test, but you can get around that in different ways by doing, as Abby said. So it is about respecting everybody in the process to make sure that we're doing that. And, you know, none of us want to cause distress to an individual in the circumstances, and it is possibly best to say that it's likely that they're in A, B or C situation and deal with it in that way. And it would be more conservative than if we had the test as a consequence.
Thank you, Kevin. Some of the queries that have arisen are around the recording of the numbers associated with schools, and how they are actually reported and recorded. So perhaps maybe just a little explanation about how the numbers have been recorded that have been associated with schools to date would be very useful.
To do two things. One, we record very clearly each day, each week, the number of positive tests amongst the different age groups. And we've even shifted it such that we equally provide now as well the numbers amongst the age groups that replicate the education system. So the 0 to 4-year-olds for the preschool, the 5 to 12-year-olds for the national school, and over 12s for the 12 to 19-year-olds for the post-primary. So we do that. So we clearly indicate how many cases there are in the children's population as a consequence. On top of that, we then do the analysis of what happens as a consequence of being identified of a case, be it in a child or a staff member in a school, and that analysis. And that's the analysis most people have seen. But it's not hiding anything, it's just very clearly saying what comes out as a consequence from that analysis. And it's there on a weekly basis very clearly for people to see as a consequence. And the numbers have actually risen. There's no two doubts about that, because the community disease has risen appreciably. But what's interesting, even in the creches now, the level of positivity is well below what it is in the overall community as a consequence. Very, very much so. It's down at 3%, 3.5%, whereas in the general community, it's still in the high teens percentage-wise. So, you know, there is still the evidence of where we are with children, that children aren't as, don't get as infected as much as adults, and don't appear to have had the same degree of severity of disease, both of which are clearly not true for every individual, but it is very much that so. The number of children, i.e. under 16, have been in ICU is countable on one hand.
And I suppose just further to come in and say that the laboratory results, they're all automated. So they go from the laboratory and they go to the HPSC, which counts and provides the daily numbers, which are presented at an effort. And then we're notified of the cases and we do the onward close contact identification and the testing, and those reports are reported. And again, that's all automated. So it doesn't go through someone to decide whether to put them up or not put them up, for example. The numbers are too huge, obviously, and they go straight from, if it's a positive diagnosis in a laboratory, it goes directly into the feed for the national reporting. Okay,
thanks for clarifying that information. One of the other questions that has been raised a little bit in the chat there relates to the school transport scheme. And I suppose just to reiterate that the scheme will be running in full for schools when they reopen during the week. There will be no reduction in the capacity or the vehicles that are running, even though the numbers returning will be much, much smaller. So therefore, there will be less occupancy on some of those services, but there will be no reduction in any of the services or the vehicles that are running in the context of the school transport scheme. Another issue that has been arising there in the chat, Kevin and Abby, relates to the vaccination programme. And I know that's not maybe something you're directly involved in, but perhaps just to comment in general about the rollout of the vaccinations, Kevin.
Yeah, I'll just say the government considered before Christmas the prioritisation, which was based on the recommendations of the National Immunisation Advisory Committee, which had looked at the level of disease in the country up until that point in time to see who would be the people who were most at risk of getting the disease and most at risk of having a severe outcome from that disease. So that left you with the groups that are there quite clearly, which was older people over 65 in nursing homes or residential care facilities and the staff working with them, and healthcare staff who are facing patients, front-facing patients. Okay, so that was it. Then it moved on to other groups, mainly based around age, and classically then the final group in general in that terms would be people under the age of 65 with a medical condition, and then moved into different groups. And it recognized that hitherto the people who had been least at risk of getting the disease had been children, and still is if you look at the numbers, and therefore as a consequence children are the last group to be immunized. Whereas when we looked back in with the swine flu 10 years ago, children were very close to the top because children were being mostly affected by it and were seen as the main vector. This time around, children aren't being seen as being actively infected by it, nor are they seen as the main vector at all. The main vector is clearly in adults aged 20 to 50. That's where the disease is spreading most and most actively in our society. So it's there. So yes, they're doing it. As with all the things you hear us talking about, these things are routinely revised and looked at, and that will carry on throughout the whole of the vaccination as we move on. But even the groups I spoke to you about actually represent just over 1 million people, close to 1.4 million people. So it's a lot. And the other key factor you have to bear in mind with the vaccination is the access to the vaccines the country has. And we don't start to have significant volumes of vaccine until March, April at the earliest. When I mean significant, I mean at least 1 million coming in a month.
Okay, thank you, Kevin. And just to say, the department is also engaging with the Department of Public Health around the vaccination and the prioritisation of school staff. But as you said, Kevin, currently the priority relates to those over 70 with underlying medical conditions, given the current phase of the rollout of the vaccination at the moment. We're coming to the end of the webinar and some of the questions that have been asked. I might just ask if Abby had any final comments around the special needs settings and the experience that we've had and how we're going to continue to support them over in these coming weeks in this interim period before we conclude.
Thanks, Deirdre. I think most of what we've said already really applies to the sector is really important, and we know how severely harmed children were from the school closures, but particularly the special educational needs sector, where they regressed on many of their achievements, their hard-won achievements over the time period before. And I work as an operational sort of public health doctor, and I definitely know from my experiences at pediatrics beforehand how important it is that we try and facilitate the care given to these children to maximise and increase their potential. And it is a difficult environment currently, and no one is saying that it isn't, but it has been a difficult environment over the previous term. And we have a term's worth of experiences that shows that actually what we can do makes a difference on a COVID level and makes a very, very significant difference on a personal level to many of these children. And we will very carefully watch what happens to make sure that any new recommendations that need to be put in place, that we will raise from our experiences on the ground and raise them to the appropriate places to get that new guidance in. And it is about considering, I suppose, as a society, who we value and need most to go out at times when we're asking everybody else to stay in, to keep it as safe as possible for those of us who do need to go out and do essential work. It's about that appropriate risk balance, and our experiences are that we can mitigate those risks very substantially by all making sure we take responsibility as a community, and obviously as a patient population and their families. That's very important, and one which is likely to be paid high attention to, facilitating the safest possible return to the education sector. We absolutely agree there is no such thing as risk-free, but we're here to give the advice of the mitigation measures in place and how to follow up on those from our perspective. And I can see Kevin wants to come in, so I'll hand over to you, Kevin.
Just a final word from myself. I have not been as proud as I've been about what's happened with the education system in the last year, since last September, and hopefully this term as well, in the whole of my medical career, which is close to 41 years. I think we have achieved an immense amount of good for children in the last 6-7 months. And it's down primarily to yourselves, some help from Abby and I, and more from our other colleagues and other people. It's been an immense effort to make sure our children are benefiting in these very, very difficult times. And I think you should be extremely proud of what you've done. It is amazing. And I really do. I'm very, very grateful for what you've done, because I think it has been one of the biggest inputs during this period that has not been recognised as a consequence. We talk about people like me and Abby and others, but we've not recognised the immense amount of work you have put in to make sure these children get properly educated. So well done. Thank you very much.
Thanks, Abby and Kevin. And just to conclude now, I'd like to thank the panel of Dr. Glynn, the Deputy Chief Medical Officer, Dr. Kelleher and Dr. Collins for their time and expertise and contribution to this webinar this afternoon. It's clear from all the feedback that's coming in that there is a great desire among teachers and SNAs and the whole school community to support the return to school for students with special education needs. And we all understand, and as Kevin and Abby have said, why face-to-face learning is so important for this group of students in particular. In that context, we as a department are going to continue to engage with the education partners on this plan for the phased reopening for children with special education needs, and also for the broader reopening of schools at the very earliest opportunity. And we will continue to work to deliver that. We will continue to stay in contact with the education partners and directly with all of you through your schools as this work progresses. We will be updating the frequently asked questions and we will be providing them on gov.ie/schools. And this webinar will also be available on that website to review after today. There will be further guidance provided directly to schools for pregnant and high-risk members of staff. And that will also be communicated as soon as possible. So I'd just like to conclude by reiterating the thanks to all of you for coming today and giving of your time and making the contributions through the chat to this webinar. So thanks to everybody and have a good evening.